I will try to be quick, compensating for the time lost. Our talk today is about IVC filter indication and contraindication. Let's have some historical background. The idea of pulmonary emboli originating from the leg veins started at the 19th century, and the idea of having ligation or interruption of the filter of the IVC itself started in the 1900s by the vascular surgeon. Then it followed by the interruption by a filter surgically in 1960s. Then the percutaneous insertion started in the 1973 by the Greenfield filter. The venous thromboembolism manifested as a deep vein thrombosis or pulmonary embolism is a serious potential lethal disorder with significant morbidity and mortality. But let's agree that the anticoagulation is the preferred #1 treatment of this. It's important to understand that the IVC filter neither treat nor prevent the venous thromboembolism, but they only prevent the potentially life-threatening complication of PE. Two types of IVC filter we know, the permanent and the temporary, the optional one. The availability of this temporary or the retrievable one or the convertible one in particular has altered the practice pattern for the IVC filter with the shift to these devices and expansion for the indication for the filter placement. Let's have this interesting study, the pre-pick, before discussing the indications. Now, this study randomized 400 patients with the proximal DVT to receive anticoagulation together with the IVC filter versus anticoagulation limb alone. In the high-risk patient with the proximal deep vein thrombosis, the initial beneficial effect of the vena cava filter for the prevention of pulmonary embolism was counterbalanced by the excess of recurrent deep vein thrombosis without any difference in mortality. This study continued for more than 8 years, and the follow-up data at 8 years showed significant fewer symptomatic PEs in the filter group. However, there were significantly more symptomatic DVTs in this group. There was no survival difference between the patients with or without filter at the 12 days, 2 years, and 8 years. Moving to the indication, we can categorize the indication for filter insertion into 3 groups: patient with VTE and classic indication, patient with VTE and extended indication, patient without VTE, but the filter is placed for primary prophylaxis against PE. First group with a classic indication, where there's an absolute contraindication to anticoagulation, like head and spine injury, recent surgery, any contraindication to stop the anticoagulation. And also, if the patient is already on anticoagulation, but the complication happened, resulting in cessation of the therapy. Failure of anticoagulation, inability to reach or maintain the therapeutic level of anticoagulation, and or documented progression of the DVT despite being on therapeutic dose of anticoagulation. The second group, the VTE group with extended indication. Now, extended is a soft terminology. Indication have been introduced into the clinical practice over time, especially with the newer generation IVC filter and being available and easier to place. This indication based on a specific risk for complication from VTE or anticoagulation. These include iliocaval DVT with large free-floating proximal DVT, difficulty in establishing therapeutic anticoagulation, massive PE treated with thrombolysis or thrombectomy, chronic PE treated with thromboangiotectomy, thrombolysis for iliocaval DVTs, VTE with limited cardiopulmonary reserve and recurrent PE with filter in place, poor compliance with anticoagulation, and high risk of complication of anticoagulation. The third group is the VTE with the primary prophylaxis, patient without VTE for primary prophylaxis against PE, like trauma patient at high risk for VTE, immobile, prolonged immobilization, patient couldn't receive a prophylactic anticoagulation, surgical procedure in a patient at high risk for VTE, like for example, bariatric surgery. In pregnant patient, however, no strong evidence supporting this. This is the summary of these three groups for the current practice. If you go through the literature, you will find the first group has a stronger evidence in regard to the insertion of IVC filter. I mean, the one with contraindication for anticoagulation. However, the prophylactic group does not have a strong evidence. Now, this aired the need for the clinical practice guidelines, and here is an interesting paper from Society of Interventional Radiology in collaboration with lots of societies, the cardiac, the thoracic surgeon, the trauma surgeon, vascular surgeon, and just physicians. This clinical guideline based on systemic review of a published study, around 34 studies with a set of around 18 questions. The SIR partnered with the American Academy for Orthopedic Surgeon, Clinical Quality and Value Unit in the Department of Research Quality, and they set up the methodology. The panel consisted of 3 interventional radiologists, 2 representatives from vascular surgery, 2 from vascular medicine cardiology, 1 from vascular medicine pulmonologist, hematologist, and trauma critical care surgeon. And here is the set of 18 questions that has to be answered while discussing these 34 studies. And here is the summary of the recommendation in regard to different clinical scenarios. And as we see, there is either weak or consensus agreement against the filter insertion in the trauma patient without VTE or for prophylactic indication, obese patient, immobile group, also supporting that the IVC filter benefit should outweigh the risk for inserting the filter. So as we discussed earlier, there is no rule for IVC filter where anticoagulation can be administered, while if there is a strong contraindication or cessation for the anticoagulation, the filter is strongly indicated. The prophylactic group or the high-risk patient where they can receive a prophylactic anticoagulation like bariatric surgery or trauma patient without documented bleed, there is no strong evidence toward IVC filter insertion. Again, the risk-benefit of anticoagulation / IVC filter should be weighed, and the retrieval for the filter, again, should be planned. Let's discuss some special indication or scenarios. A suprarenal placement of IVC filter. As you know, if there is a presence of IVC thrombus precluding the placement of the filter at the infrarenal portion. Also, during pregnancy, the gravid uterus will expand in the lower abdomen, and the placement for suprarenal placement is a good choice in terms of physical position and for radiation prevention. So the radiation will focus away from the gravid uterus as possible. thrombus extending above the previously placed infrarenal filter also is indication for suprarenal. A large gonadal vein thrombosis, anatomical variant like duplicated IVC, circumferential renal vein with a lower insertion of the retroaortic, significant extrinsic compression at the infrarenal IVC, and intrinsic narrowing of the infrarenal IVC. About the SVC filter, the upper extremity DVT with contraindication or failure of anticoagulation, also DVT with PE with the same scenario, or thrombus extension despite anticoagulation. In case of free floating clot with risk of embolization, also is a good indication for SVC filter, but it has it has to be a good caliber IVC, SVC, sorry, not larger than 30 millimeter in order to prevent the migration of the filter. Also, if there is an extensive SVC thrombus, this will preclude the insertion. In case of uncorrectable significant coagulopathy and patient with venous pacemaker. In regard to the IVC filter contraindication, the absolute contraindication is the inability to gain venous access, whether from above, jugular, arms, or femorals, or as my colleague mentioned, the great saphenous accesses. Complete thrombosis of the IVC also will preclude the filter placement. Relative contraindication would include the incorrectable severe coagulopathy, bacteremia, or sepsis. To sum up, vena cava interruption currently accomplished by percutaneous filter insertion. It's an important therapeutic option in the management of selected patients with VTE. The availability of the optional filter altered the practice pattern for IVC filter with the shift to these devices and expansion of the indication for the filter placement. And new devices have become available and clinicians have become more familiar and comfortable with IVC filter. The indications for the filter placement have continued to evolve and expand. In the present clinical practice guideline, there is a strong need to provide an evidence-based recommendation balancing the benefit and harm associated with the use of the placement of filter with the removal or conversion of these filter in the treatment of VTE and prevention of PE. Thank you very much.